around for a very long time. And the question is, why should we be talking about it? I have nothing to declare and no conflict of interest. As I said, why should we be talking about total parenteral nutrition? A recent survey carried out by Nick Emberton from Newcastle in UK, looking at high-income European countries, surprisingly, just over a third start protein too late in giving their TPN, or even when they give protein, they give too little protein in their TPN. The same is the case. Over 60% of neonatologists start with too little lipids in starting the TPN. And most importantly, and most worryingly, nearly 43% do not meet the recommended caloric target. Now, why is this important? Because, okay, if this is so, why are they doing this, and why should we not get everything right? And why is it important? It is important because from 24 weeks onwards till birth, the main organ which is growing is the brain. And so energy, amino acids, and lipids are required for the various development of the brain. And if you don't provide adequate energy, adequate amino acids, or adequate lipids, then you're not going to develop the brain as the potential of that particular brain is. So it becomes extremely important that we get our TPN right and we give the requirements which meet the brain growth of a newborn baby. So in the next 20 minutes, remaining 20 minutes, I want to talk about what we need to know about TPN, what is in TPN, indications and contraindications for using TPN, meeting the macro and micronutrient requirements. When should we start TPN? Principles of protein, lipid, and carbohydrate infusion. How do we prescribe TPN? How do we give TPN? And the risk associated with TPN. But before I talk about TPN, I think it's important to stress that enteral feeding, oral feeding, is always preferable to parenteral nutrition. But in cases where you cannot give enteral nutrition for one reason or the other, TPN is the provision of complete intravenous nutrition, including fluids, sugar, protein, lipids, and micronutrients, including electrolytes, vitamins, and minerals, where oral feeding is not possible. Now, having said that enteral feeding is the most preferable way, but sometimes you have to give TPN. TPN really is a bridge towards achieving enteral feeds in the baby. Now, this bridge, like any bridge, must be strong. And to provide TPN, we must provide total nutrition which meets the metabolic and growth needs of that particular infant. But in providing that, we must have very safe systems of supply, storage, and preparation of TPN. We need to know how to prescribe it and how to give it. And we need to have policies and procedures in place so that we don't randomly use TPN. And one of the reasons why the first slide, which shows you that there is discrepancy in the amount of protein, lipids, or when to start, is because of lack of standard protocol. Now, TPN is available in two versions, standard versus individualized TPN. Standard version, which you can buy commercially, is cheaper, easier to use, safer, but needs addition of electrolytes and sodium and potassium and phosphate and calcium. The individualized TPN, which is made in your local hospital pharmacy, is very expensive to set up first thing, and then to prepare it is more prone to errors. There are maybe compatibility issues and needs special pharmacy. Of the standard solutions, we have three kinds. The starter solution, that is the solution which we start off with. There's a solution which has high protein, that is high density. The calories are dense, and then there is restricted fluid volume, that is, you can give the same TPN, but in a smaller volume in situations where you don't want to give the total amount of fluid which the baby requires. So what is in TPN? Basically two things, the macronutrients, which are carbohydrate and dextrose, amino acids, and lipids. Now, the carbohydrate is basically dextrose sugar. The amino acids are prepared commercially to copy what is the amino acid pattern in the breast milk or in cord blood of term infants. And so sometimes it is not quite adequate for preterm infants. And lipids, most often people use soybean, but now, which is much more fashionable to use the soybean plus MCT plus olive oil plus fish oil, because that is the main source of energy, giving 9 calories per gram. And of course, there are micronutrients like electrolytes, zinc, selenium, and other micronutrients, plus vitamins, which we use. The basic rule is that carbohydrates should be between 50 and 55% of TPN, lipids about 35, and protein between 10 and 15%. Indications, as I said, preterm infants and children who will not reach full peak in 3 to 4 days.
Excuse me, please. Excuse me.
Yes.
Your PowerPoint are not shared.
Oh, it is shared.
No, we see you, but we don't see your slides.
Okay, here
Let's do it again.
Yeah, let me do it again. I go for my slides.
Please.
Share.
Yes.
Is that?
Yes.
The standard solutions which you can buy commercially come in three varieties. Starter solution, that is the solution which we start off with, the high protein, which is energy dense, where the protein levels are slightly higher, and the restricted one, where for some reason, if you want to restrict fluids, but you still want to give the calories, then you use that particular solution. What is in the TPN? Macronutrients and micronutrients. Macronutrients, basically carbohydrate, dextrose, amino acids, which are based on breast milk or cord blood, amino acid pattern of term infants, and therefore may not be quite appropriate for very preterm infants. Lipids, mainly from soybean, but now we tend to use lipids which are made from a combination of soybean, MCT oil, olive oil, and fish oil, and of course the micronutrients. The usual distribution of calories is 50 to 55% coming from carbohydrate, 30 to 35% coming from lipids, and 10 to 15% coming from protein. As I said, who do we give TPN? Babies or children who cannot take feeds orally, most often after gastrointestinal surgery, certainly in the neonate necrotizing enterocolitis, or when the baby is severely ill, like septicemia or cardiac failure, respiratory distress, and some metabolic conditions. There are very few contraindications to TPN. Hyperbilirubinemia, that may be a contraindication for lipids, but it is a relative contraindication. Thrombocytopenia, shock, or azotemia. Severe liver disease because of the protein metabolism, coagulopathy, and some very, very rare inborn errors of metabolism. Next question is when to start TPN, early or late? Early TPN provides better growth and also reduce mortality. But there is a very big but. If you start TPN early, because you have to give it for prolonged period, the morbidity secondary to infection from TPN is much higher if you start early. And there's a study by Moon showing 27% versus 10%. So actually the infection rate doubles if you start early. So you have to balance whether you're going to start early or late. What about starter solutions? Now, those of us who do neonatology day in and day out, the tradition has been that we restrict electrolytes in the first 24, 48 hours. When we give only dextrose, or sometimes we add amino acids. But 2 points I just want to make on this slide is to remember that the intrauterine accretion of protein is high. It's about 4 to 5 grams per kilo per day. But once you clamp the cord, that supply finishes and it goes down to zero. And so if you're starting even on day zero and by starting small amounts of protein, it takes a little while before you can come to the accretion rates which the baby was getting in utero. And so you create a gap and a protein deficit. And that is one of the reasons why there is extrauterine growth restriction in preterm infants. And John Osborne has shown that giving higher protein is better than giving no protein or very little protein. But something which is also we have discussed, we now have learned from the Provide trial by Barbara Cormack from New Zealand, where what she did was to use the standard TPN in babies less than 1,000 grams, but gave a gram of extra protein every day. And what she did find and compared it, what she did find is that if you don't give electrolytes in the first 24, 48 hours, you have a very high chance of hypophosphatemia, you have a high chance of refeeding syndrome. And also severe hypophosphatemia. So this is something which neonatologists often forget, that the refeeding syndrome is quite important when you are giving TPN and if you don't give amino acids early. What is refeeding syndrome? Don't give enough amino acids. This increases the phosphate usage in energy production cells because the cells are rapidly developing. It depletes the blood for phosphate, potassium, and magnesium. Now, this has to be made up from the bone. And so if the bone puts out phosphate and calcium, and you get low phosphate and high high calcium in the blood, and this has been shown that it increases chances of death, it increases chances of necrotizing enterocolitis, grade 3 and grade 4 hemorrhage, and retinopathy. So refeeding syndrome is important. It leads to heart failure, BPD, IVH, and even long-term survival is 3 to 5 times more likely to have neurodisability. So we need to pay attention to refeeding syndrome, and that's what Barbara McCormack has suggested, and what we have now implemented is we have now revised the starter protocol. We give more protein, we add electrolytes, and we particularly add calcium and phosphate. Again, the question whether early protein works or doesn't work, the meta-analysis shows that weight on discharge has a tendency, though it crosses the one line, but rate of discharge is better, survival at discharge is better, and certainly the neurodisability is less, and cerebral palsy is much less. Now, some facts about amino acids, I don't need to teach you, but you know there are essential amino acids without which the body cannot work. There are conditionally essential amino acids. These amino acids become essential when the baby is stressed, and then there is non-essential amino acids which the baby can make itself. Now, the interesting point is that, as I said earlier, nearly all TPN solutions do not meet the same, are not very similar to the amino acid pattern of breast milk or the cord milk. The dark, bright red is breast milk, and here what I've pointed out in the TPN solutions, sometimes they have a much higher amino acid and sometimes they have much lower amino acid content. So the amino acid preparations which we use do not necessarily match, and therefore we have to be very careful about amino acid deficiency when we are giving TPN. Protein, 3 to 4 grams a day, determined infant needs a little less. But what is important is to remember that the protein will not be absorbed just by itself. It needs non-protein calories to help it get absorbed. And there is a formula which you can use it. It is called the non-protein energy ratio, which you can calculate how much non-protein calories you need to give for the protein each gram of protein to be accreted. The same thing is for lipid. We usually use 20% solution. We start from 1 to 2 grams per kilo per day from day of birth, and we achieve about 3 to 4 grams per kilo per day in the next 72 hours. That's our policy. We do not routinely measure serum triglycerides. We do not stop intralipid because of jaundice unless it is in the exchange zone. We always cover lipid bag in the tubing to reduce oxidant load. This is our policy. You may differ with it, and we can discuss it in question time if necessary. Carbohydrate is the main source of energy along with lipids, and we tend to give about 50 to 55% of total TPN calories from carbohydrate. But what is important to remember is that in a sick infant, hyperglycemia will reduce the amount of dextrose. We reduce the amount of dextrose because there's problems with insulin resistance and glucose uptake. We usually use between 4 to 8 milligram per kilogram per minute, but can go to a maximum of 12 milligram per kilogram per minute of glucose. Our practice, we start on day 0, on the day of birth. We might wait in a little older child, maybe 35 weeks or more. We might wait for 24, 48 hours, but certainly we will start on day 0 for most babies in our. The reason why we delay giving it to babies who are sick or stressed is this, because when the baby is stressed, here you are in inflammation, and this is in hypoxia. Stress increases catecholamines, cortisol, and glucagon, and therefore already increases the free amino acids and free fatty acids in the blood. And therefore, during the acute phase and just before the baby is fully stabilized, we reduce our TPN by 50%. And this is what most people do, but some people do not agree with that. what is in our bag? We tend to use 3 to 1 bag, all in one, the intralipid, amino acid, and dextrose. And as I said, it contains all the things along, and we add some vitamins and minerals. How do we prescribe? Now, the tedious method is, of course, you calculate how much volume you want to give, then you calculate how much protein you want to give, then you calculate how much lipid you want to give and the micronutrients you want to give. And then once you have that total, which I've calculated here for a 1 kilo baby who's 2 days old, the total comes to about 52 mils. So you take it out from, I was going to give this baby 120 mils, so you take it out from the 120. So carbohydrate, you need to give 77.8 mils. Then you need to calculate what is the glucose infusion rate. We said, let us say here 5 milligram per kilogram per minute. You have a standard formula and you calculate, and I get 9.2% dextrose we need to use. So we round it up for 10%. Now, this is a tedious method of doing that. And once you do this, you then send it to your pharmacy or electronically or in a paper sheet. But now there are many, many apps which can give you the same answer. I mean, those calculations will take me about 20 to 30 minutes to do. Now, if you put the same data onto ChatGPT or any other app, you will get the same prescription ready to go to the pharmacy within 5 to 10 seconds. And most people are now using this. How do we give TPN? The only point I want to make is that if the osmolality is more than 900 milliosmoles, or you're giving more than 12.5% dextrose, then you should not give it through a central line. Otherwise, you can give it through a peripheral line. Monitoring, everyone has their own protocol. We do it like this, but you can have your own protocol. But the message is earlier on TPN, more monitoring. Later on, less and less monitoring is required. Once the baby is stable, complications, we all know the most common complication is with the catheter and related, whether it leaks out and you get thrombosis, infarction, or this is very important. Here was an antibiotic given, and that precipitated in the TPN line, and you can see there's particles in the lung. And so you can get cardiac tamponade if your central line is somewhere there, metabolic disorders, cholestasis, as I've already mentioned, and of course, if you don't give adequate calories. So there are dextrose can give you hyper or hypoglycemia if you give too much or too little, hyperlipidemia, rash. But then there are many complications of TPN. At hospital level, you should have good supply, standardized solution. At the neonatal unit level, robust guidelines, regular audit, quality improvement, and patient catheter is the most important. Insertion of catheter, it should be sterile, and the line should be maintained as sterile as possible. So I hope I have gone quickly on time. The summary is enteral feeding should always be preferred if possible. TPN should be started early and given for a minimum possible time. Asepsis should be maintained at all times. Adequate amount of protein, lipids, and carbohydrate, electrolyte, and micronutrients should be given to prevent refeeding syndrome, monitor for complications, and monitor growth. These are my references, and I thank you for your attention.
Dr. Khaled, thank you very much for your presentation. But sometimes while we're working in the neonatal unit, 1 kilogram baby, we couldn't give him the total TPN that is required because of the volume. What do you advise?
As I showed you, there are two ways of doing that. One is to use a high protein, low volume solution, which is available commercially. So you can give the same calories and same protein, but in a reduced volume. So you can get a standard commercial solution if you like. Or if you're going to make it yourself, perhaps you can make it denser, because calorie requirement is important, because meeting the amino acid requirement and lipid requirement is important. Volume can be altered, and particularly volume of the dextrose is altered frequently.
Okay. Regarding refeeding syndrome, have you seen it in neonatal unit?
Yes, sir. Yes, I have seen it. I have seen it. Not, and in fact, people in the past, people ignored it. They did not recognize, they saw it, but they thought, oh, well, this is just one of those things, and we'll start. But now I think there is very good evidence that we should be adding phosphate and calcium and a little bit of sodium and potassium early on from day zero in TPN.
Okay. I have seen somebody was presenting, had a presentation about TPN. He was showing us a photo for protein, energy, malnutrition child skin.
Yes.
And he said, this is the brain looks like this. If the baby doesn't receive TPN and the calories and protein, etc. What do you think?
I think one of the things which you get skin deficiency rashes is particularly zinc deficiency, and we need to be very clear. Selenium and zinc are two very, very important things which we don't often look. We just say, oh, we give TPN and we assume that there's enough selenium and enough zinc. And also now more and more people are reporting copper deficiency. Okay. And it's interesting how these things are coming. And the reason for that is why we are finding it out is because we are now helping smaller and smaller babies to survive, and we are giving more and more TPN, and we are giving it for longer and longer. And so we are seeing the spectrum of deficiency of our therapy.
Okay. Thank you very much indeed.
Welcome. I'm sorry about the.
No. It's an outstanding presentation. Thank you very much.
Thank you. Welcome. Thank you.
Thank you very much indeed. Now, this is the time to hear our dear friend and Professor